You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for healthcare professionals. I'm Dr. Ken Miller. I'm a medical oncologist, a hematologist, and an LLS volunteer. And I want to thank all of you so much for joining us on this episode. Today we'll be discussing acute myeloid leukemia, including how molecular mutations, diagnostic tools, and risk-based strategies are transforming the treatment of this disease, but also insights on frontline therapies, the LLS Beat AML master trial, emerging treatments, and key developments from recent clinical trials. We're delighted to be joined by Dr. Uma Barate, who is an associate professor in the Division of Hematology and the Acute Leukemia Clinical Research Disease Group leader at The Ohio State University in Columbus, Ohio. Uma, thanks for joining us.
Thank you so much for having me. Really grateful to you and the Leukemia Lymphoma Society for giving me this opportunity. Thank you.
Uma, we're going to talk today about AML in general, but for a few minutes, let's talk about pediatric AML. I'd love to learn more, and our listeners as well, about AML in children and characteristics of the disease, the presentation.
You know, acute myeloid leukemia, as you just pointed out, Ken, is not common in children. We often hear about ALL in children. ALL in children is a huge success story. We have cure rates upwards of 90%. And I think this disease not kind of strike fear into people's hearts the way we have with AML. AML in children, unfortunately, still tends to be pretty challenging. I think the mainstay of treatment in AML in children still happens to be different types of chemotherapy. But I will mention one pretty significant advance that has happened in AML in children. And I think that is to do with the fact that a large subset of children with AML present with what we call KMT2A rearranged acute myeloid leukemia. It's a very specific rearrangement in chromosomes that happens mostly in children and young adults. And we really didn't have a lot of options for treating this type of leukemia. This is unfortunately very, very common actually in infants, really. So children between 0 months to 12 months. And it was almost universally fatal. But now we have a new class of targeted therapies that we refer to as menin inhibitors. These are small molecule drugs that target this specific rearrangement. And we've seen some really great successes in the adult world. And obviously, we're all very excited to hopefully move this into pediatrics. We've got some data in children as well. And so I think in my mind, this is sort of the first step to advance care in AML in children. And hopefully there'll be a lot more options to follow in the next few years.
We've been getting, at least on the adult side, information about the menin inhibitors. So it's exciting to hear that it's useful in a whole spectrum of ages. Using your perspective as an AML specialist in adults and looking at the spectrum of the disease, how else, in your view, is childhood leukemia, AML, different than in adults? I know that one of the things you've published on is sort of the molecular landscape.
I think that's a great question, Ken. And I think the landscape in children is very different from the landscape in adults. And again, speaking mostly to the adult setting, and by adult, I think the universal definition in most studies is when you're age 18 or older. However, as you know, there is a spectrum of what we call adults, in that there's young adults, right? And this is what we refer to in people up to the age of 40. And then there's the real adults that are the people over the age of 40.
Okay.
And I think the molecular spectrum in children and young adults is different than in adults over the age of 40. And I would say, especially in young adults, we call these the AYA population, adolescent young adults, we do see much more KMT2A rearranged AML. We do see much more NPM1 mutated AML. And we also see much more favorable risk, as we call them, AML. And these are AML patients that have a couple of abnormalities. Inversion 16 is one. The 821 translocation is the other. And I think the good thing about these diseases is that they are curative. They're curative with chemotherapy. We have these very advanced techniques called assessing minimal residual disease that we can use in these folks to follow them carefully and detect an impending relapse earlier. And so I think for the children and the AYA age group, we have a spectrum of molecular abnormalities and chromosomal abnormalities that are somewhat unique than adults age 40 and older. And we can go into that in detail as well.
So I'm going to bring up the example of lung cancer because it's something that I deal with a lot, but more to look at a model. A lot of the younger adults that I see with lung cancer who were never smokers have a driver mutation. It could be ALK or ROS or EGFR, etc. A lot of older adults who've been heavy smokers, are less likely to have that. Is there a way to think through childhood and adult leukemia from that perspective or from any other model that you use to think about why children are presenting with certain types of AML and adults with others?
I think you kind of hit the nail on the head. It's very, very different diseases. And I think it's because, as you mentioned, the drivers of the disease are very different in a childhood AYA population compared to an adult population. Unfortunately, in the adult population, the drivers tend to be, I think, more due to age-related changes, including age-related mutations. We call that clonal hematopoiesis that have then kind of progressed to become more aggressive myeloid malignancies. They also have a higher incidence of what we call treatment-related AML, which, as you pointed out, we're really good at treating all other cancers now, including lung cancer. And I'm actually seeing patients who have survived lung cancer to now have treatment-related AML, which a few years ago that was unheard of because they were passing away from their original cancer. And so I think the drivers of older AML are just very different from younger AML patients, where the drivers are certain translocation and targeted mutations that I think we now have more therapies for. But I don't want to make the audience feel like, all is dismal in the older AML group. I think this is something that I'm very passionate about. And we'll talk about some of the efforts the Leukemia Lymphoma Society has made specifically in older patients with AML in order to bring more targeted therapies to them. So I definitely think we are making advances in all age groups in AML. But you are absolutely right in that younger AML is just a different disease than when it affects older folks.
So I wanted to ask you about the group of patients who years ago we would have said, oh, normal cytogenetics. The group of patients where you really don't detect a specific mutation or something that you think is driving the cancer. What are your thoughts in terms of what caused that cancer and what's causing that cancer to sustain itself?
In what we call the European Leukemia Net, we call it the ELN classification. And that's really what we've all relied on to tell us where does the AML that we diagnose fall in the spectrum in terms of risk categorization, treatment option, etc. If you look at the ELN 2017 classification, it basically has this large group of patients, right, that are classified as intermediate risk. And intermediate risk essentially means, as you said, cytogenetically, if you were to do cytogenetics on these folks, they would have normal cytogenetics, 46XX, XY, whatever. But if you were to do this test now that is very widely available and actually, luckily, quite inexpensive, which we call next generation sequencing. And all of us at places we work have labs that we contract with that do this next generation sequencing on a certain number of genes that are implicated in acute myeloid leukemia. If you were to do this test on those cytogenetically normal patients, almost all, if not all, have certain mutations in these myeloid genes that have led to this disease. And the biggest group of them was NPM1 mutated patients. Now, these NPM1 mutated patients, NPM1 is a big gene and it can co-occur with many other genes. So 1/3 of NPM1 mutated patients would co-occur with FLT3, and FLT3 mutations were considered poor risk, but the ELN classification has then evolved to now, if you are NPM1 and FLT3 mutated with normal cytogenetics, you're not necessarily poor risk, you could still be intermediate risk. It can co-occur with IDH mutations, which now we have targeted therapies for those. It can co-occur with multiple other mutations. including DNMT3A and TET2. We don't really have targets for those. So that's one gene that can be found in these patients. And then you have several other gene mutations like spliceosome mutations, CHIP mutations, many others that unfortunately we still don't have targets for, but that all are part of the cytogenetically normal group. I would go so as far to say, if you have a cytogenetically normal AML patient and you cannot find a gene mutation that's causing their leukemia, there's something really wrong with the test or the
Wow.
sample. I would
Yeah.
rethink,
Yeah.
does
Wow.
this patient sample get mixed up with somebody else's or something like that? That's how good we've gotten at
Wow.
figuring out. Yeah,
Yeah.
exactly. So that's just from 2017 to today. And that's not even a long time in our world. So I think that's pretty cool.
Yeah, I think it's very cool. I thought you might say, well, it's epigenetics, but it sounds like some of it may be a lab issue.
I think it's just how big is your NGS panel. If your NGS panel just covers 9 or 10 genes, you're missing about 30 genes that could be the result of those mutations could be causing the AML. So in general, most panels now are between 40 to 100 genes. Some go even higher. But really, you're right in that epigenetic changes do play a role in all of our cancer causes, including AML, but they are typically identified by certain gene mutations. So if it's not being detected, I would question the number of genes on your panel or the quality of the sample.
All right, thank you. So I wanted to ask you about pathophysiology. For any gene that you choose, that would be interesting. How does one of these gene mutations, again, of your choosing, lead to the mechanism for a person's leukemia? What is there about, and again, it could be any of these genes. Tell us that story, if you would.
I think this is a great question because I think it's a very sort of biology 101 question. And I think we get so wrapped up in diagnosis and treatment that we sort of forget the underpinnings of why this disease developed in the first place. So I'll give you an example, and I'll give you an example of somebody more likely in their 60s that developed AML, because the most common age group that people develop this disease is in their 60s. And I would say this could be a person that's gone about their whole lives not having other cancers, not smoking, not drinking, taking reasonably good care of themselves, right? Just by the fact that somebody has gone through life and survived into their 60s means, and we know this because now we've sequenced people in their 30s, 40s, and 50s, and even in their 20s. Generally, our stem cells unfortunately age. I think there's always a famous saying, the two things in life that are for certain is death and taxes. And I would say the two things in life that are certain is aging and taxes, because death's a binary thing. You're either dead or you're alive, but you age for a long time for most of us, hopefully
Well
before that
said.
happens, right? And I think while we're aging, our DNA repair mechanisms, our stem cells, every cell in our body starts to age at the same time. And we know that in the bone marrow with the hematopoietic stem cells, there are certain mutations that accumulate over time that are to do with aging. And these are what we call the CHIP mutations. CHIP is a sort of an acronym for clonal hematopoiesis. These are mutations about 10% of us will have, normal people walking around will have over the age of 70. And these mutations sort of have this fertile soil, so as to speak. They provide an advantage for these clones to grow. And all it takes is for one of those clones then to acquire what you just referred to, the driver mutation. That one mutation, which is so potent, which is so powerful, which is so hijacks the machinery of the cell. So an example would be FLT3. And FLT3 signals through this RAS sort of signaling pathway. And all it does, it's like, I tell my patients, it's like if you're driving a car, you never take your foot off the gas. That's not normally how you ever drive a car. And we're not race car drivers. Even race car drivers have to take their foot off the gas. But there's a mutation now that will not take the foot off the gas. So these cells are just multiplying. They just go, 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 go. And that's what it takes to develop AML. And our job as physicians, as scientists, is to find that abnormality and to hopefully shut it down in order to treat our patients and make them feel better.
What are some of the success stories that you're excited about and proud of in terms of our progress in treating AML?
I get a little bit emotional when I think about this because I can tell you when I was a fellow doing this and I knew I wanted to do blood cancers, when I would round with my attending, we had no other options to give our patients. We would tell them, you know, You get chemo, and if you don't have one of these favorable risk diseases, we know you're going to relapse and you're unfortunately not going to live for maybe, the first few years. And I remember at the end of my fellowship, there was this clinical trial where people were like, oh, there's this mutation called FLT3, and let's randomize patients to getting chemo versus this chemo with the FLT3 inhibitor. And I was like, oh my God, great, let's do this. And many years later, the results came out, and this was the first, I think, targeted therapy that showed promise in AML. And since then, I am very, very fortunate to be working in this field because the floodgates have opened. So we have FLT3 mutations we can target, both ITD and TKD. That was followed by the IDH inhibitors that can target IDH1 and IDH2. We didn't really have a way to target NPM1, which we now do because of the menin inhibitors. We definitely are making progress in targeting other sort of untargetable mutations. So I think there's lots of efforts to maybe target RAS. It's been successfully done in other solid tumors, as you know better than I do. And it was considered the undruggable gene, right? But we haven't really capitalized that in the leukemia world. So I'm hoping we can somehow learn from our solid tumor colleagues and kind of do that. So I think between the targets I just mentioned and the fact that you can combine these with each other, you're talking about over, I don't know, 30 to 40% of your sort of cytogenetically normal leukemia. What we haven't been able to target are the secondary mutations, spliceosome mutations, for an example. We have not been able to target TP53, which I think is universal across cancers, and we're all struggling with what we call the common enemy. So I think those are where there's definitely challenges and opportunities.
It may be an unfair question, but if we look at APL, promyelocytic leukemia, it reminds me in some way of treatment for CML, where there was a quantum leap in terms of being able to cure the disease. APL, that's happened. Do you see that happening in some of the other subtypes of acute leukemia?
And I think that's a great analogy. And I think APL truly was one of those serendipitous things that it's a very specific translocation. Just to remind the audience, it's translocation between part of chromosome 15 and part of chromosome 17. We call it the 15-17 translocation, but it leads to this unique protein called PML-RAR alpha. And for those of us who are really into acne prevention or anti-aging, the retinoids are all in the news, right? Everybody's using retinoid cream. It used to be an acne treatment, but the same thing is used to prevent aging. And the RAR alpha receptor is that. It's the retinoic acid receptor. And so it's essentially this very sophisticated, potent vitamin A that you can give patients with this type of leukemia that really antagonizes this PML-RAR alpha protein and removes this maturation block. And miraculously, and I do call it miraculous because these people come in really sick. These patients, their white count gets better, they get better, all of their coagulation abnormalities reverse. Obviously, it takes a lot of care and a lot of supportive treatments to get them through this period. But to your point, it's really did revolutionize the fact that these patients were dying within days and now are essentially cured with the right type of treatment. So I think to your second question of where you can see that potentially in AML, I would say the menin inhibitors are somewhat similar to your CML analogy because menin inhibition really sort of removes this maturation block. And just like CML, which we have 3 or 4 or 5 different TKIs that you can use in patients that have various resistance mutations, we are now in the early stages of learning that if you treat with one menin inhibitor, right, you get a response, but you also develop resistance. And so now, can you use these other drugs to leverage the fact that resistance mutations can occur at different locations? And can you, like CML, have 3 or 4 different options for different resistance mutations? So if one patient unfortunately develops one, you have another one to follow it up with. So it's still a little bit early, and I think there's going to be lots of data presented at the conferences in the next few months to shed some light on that. But I think we're definitely heading in the right direction.
I'm actually sort of shaking my head saying, my God, this is terrific. I do remember, be interested in any of your memories too, but I remember my first month of clinical rotation was third year and it was leukemia. And I remember a few of the patients, and this is from 35 years ago, one of whom I remember I've heard from my attending, who's now retired, but is a 35-year survivor. And there were several others who died who I remember quite well. Do you have any of those memories from training?
I think it just depends on how much time you have. I feel
Uh,
like
yeah.
I feel like I have all of them. I have the really, really good memories of, patients coming in really sick. One of them really stood out to me. And this was this young mother. I think her kids were, and you always sort of, I know this is weird, but when you have patients that are the same age as you, have the same family
Yes,
dynamic as you, have children, you sort of see them in that light because you can imagine their life better, right? Because you're living that life. And I remember her,
absolutely.
yeah, exactly, having young children, and her focus was obviously her disease, and she was in shock, but it was like, I have to have this Christmas with them. There's this list we have, and there's these things we need to get through. I always say life is about the short wins. Like, I mean, nobody can say where you and I will be 20 years from now. I just think that's a little bit, you just can't predict it. But I think what we can as cancer doctors, especially, get our patients to the next most important thing. And so to me, it was very important for her that she be home for Christmas. And we did a lot of different things to make that happen. And I think we were successful. She was able to celebrate Christmas. She had a long, hard road ahead of her. She went through transplant, but now she's, for lack of a better word, I hopefully cured. She's not at that 5-year mark yet. And is obviously spending many more Christmases with her children, which is always a goal for us, for our patients. So that's always something that I remember. It was like, we got to get her home for Christmas, guys. Like, let's just make this happen. I also feel like I have some not so happy stories. And I think those stick with you because it's just the nature of what we do.
Yep. Yep.
But I just think there's just so many. There's just so many. I think we could like talk about this for hours.
Yeah, yeah. By the way, I think as some of the listeners know, but my wife is well. It's been 26 years since she had AML. So thankfully diagnosed and treated. And it's been, our kids are 26 years older and grandchildren now. So there's a lot to be thankful for. And I want to just reminisce about we got a lot of great support from LLS at the time. So nice to share good
And I'm so
stories.
happy to hear that, Ken. I mean, that's really why we do what we do.
Absolutely. Today, for someone diagnosed with AML, what would be a standard approach to treatment?
So I think that question is a great one, but it's a little challenging because I think it is totally dependent on their type of AML. And again, not to belabor the lung cancer analogy, but as you know, if you had a patient come to you with lung cancer, there's no standard approach. You are going to get the tissue, you're going to send it out for all kinds of diagnostics. And as you
Yep.
mentioned, you've got the non-smoker that you treat one way with KRAS or whatever mutation. And then you've got the heavy smoker with a totally different genotype and phenotype that you treat a completely different way. And so I think AML is very similar in that the diagnostics are what drive the treatment, because the diagnostics are what determine their risk stratification, their prognosis, and their treatment options. So it could be as varied as chemotherapy, it could be targeted therapy, it could be chemotherapy plus targeted therapy, it could be in slightly less intensive chemotherapy induction like azacitidine venetoclax, it could be a triplet, it could be an alternative induction regimen. So I just think the possibilities are really, really wide. And it boils down to, what do we find is, like you said, the driver and the phenotype and the genotype of that AML.
Again, there's been so much written about and talked about breakthrough treatments for ALL. So I wanted to ask you about transplant. And also, is there a role for CAR T? Is there a role for bispecifics? Is there a role for immunotherapy? Sort of treatments that are being used in other diseases.
I think that is a fantastic question, Ken, because we get it from our patients all the time. So I'm hopeful that when we talk about it today, there'll be some clarity around that. So I'll
Good.
sort of answer your last few questions first, and then we can talk about transplant. So I think AML is, unfortunately, or fortunately, we can talk about that in a second, one of those cancers where we don't really see some of the benefits that other cancer types have seen with, for example, you mentioned immunotherapy. So obviously there's been incredible advances with immunotherapy in the solid tumor world, whether it's lung cancer, bladder cancer. Obviously, drugs like pembrolizumab and others have just transformed the field. Melanoma, again, comes to mind. We have tried and tested those drugs in AML and have not seen the same kind of responses or success stories. I just think it's a different cancer with a different immune microenvironment. And so immunotherapy, though still being explored in clinical trials, has not had the potential transformative effect that it has in other cancers. In terms of bispecifics, there are lots of bispecifics in clinical trials, but none have been approved or are close to approval, to my knowledge, in the AML space. And I think this goes back to the same reason why CAR T is not a slam dunk in AML, just like it is in ALL or in lymphomas. It's because in lymphomas and ALL, there is a very well-defined antigen on the cancer cell, right? The cancer cell is a lymphocyte. It's typically a B lymphocyte. It has CD20 and CD19 and CD22. And if you get rid of your B lymphocytes, you're not going to have the greatest life because you're at risk of infection and your immune system isn't solid, but you're not going to die right away because you don't have B cells. We have great treatments for people that lack B cells. We can give them IVIG and antibodies externally. We can do different things to help their immune system and prevent infection. However, in the case of AML, the cancer cell and your normal stem cells that are really needed for all blood cell production, for everything, they have the same exact antigen on them. So if I were to develop a CAR T that wiped out all the AML stem cells, I would really be wiping out everything else too. And we don't have a way for them to regenerate and the CAR T cells not attack them again. So the field is really struggling with that. I don't think that it's imminent anytime soon that we'll have a breakthrough in CAR T therapy, but we're obviously very, very smart as a species. So I'm very excited and I'm hopeful that we will get around this challenge. And maybe in the next 10 years, we'll be able to have CAR T therapy for AML patients. And then last but not the least, you mentioned transplant. People talk about immunotherapy. Transplant has been the oldest and most well-studied immunotherapy because you're really replacing the patient's immune system. You're just doing it in a very, very dramatic, all or none fashion, right? You're killing off their own bone marrow, you're putting somebody else's stem cells, and then the donor stem cells are populating a different body, really. I mean, it's as close to sci-fi as you can get, honestly. However, that I think is still our cornerstone of curative therapy in AML. So a lot of our AML patients that are not going to be cured by chemotherapy or our targeted therapies, we really prioritize transplant for them. I think the cool thing about transplant that was not the case, again, when I was a fellow or when your wife had this disease, is that the donor options were very limited. You had to have somebody in your family who was a perfect match for you to be able to survive a transplant. And that is just not true anymore. You can have an unrelated match, you can have a mismatched donor, you can have a haplo donor. And we have made such strides in our treatments and supportive care that it essentially gives people the same outlook as somebody with a completely match related donor. And I think that's the success story of transplant.
But let me ask you, based on sort of where we're at with transplant, you were talking about CAR T. Let me ask you, because this is what you live and breathe each day, what would be your prediction for 10 years from now, treatment for AML, from diagnosis till the end of treatment?
Yeah, that's a great question. And at the risk of being called a nerd, I definitely spend some of my spare time thinking about these things. I think we are going to continue to make breakthroughs in targeted treatments, very similar to the example you gave with lung cancer, right? I mean, gosh, who would have thought we would have had these kind of options the way we do for our lung cancer patients, even like 5 or 10 years ago? There's no way.
Right. Absolutely.
And it's incredible. And so I think AML will go the same way, and it already is. And so I think we will find more and more genes that were considered undruggable, untargetable, that we will be able to target. So that's one hopeful prediction. I do think we are not close to the success story of CAR T or bispecifics as we've seen in myeloma or lymphoma. I think we have more struggles there, but there's more opportunity there as well. And I think if we can find the right target, I think we have lots of learnings from using CAR T in other blood cancers that we can then, translate to AML, hopefully in a pretty straightforward way.
I'd love to hear a little bit more about the Beat AML trial. What is that and what's coming out of it so far?
So the Beat AML trial is a precision oncology basket trial for older patients with AML. So we've again had a lot of these basket trials. And for the audience, just as a reminder, a basket trial is a trial where you have one diagnosis. It can be any cancer. And we've seen this with many different cancers. And anybody with that cancer can get on this trial. And then inside the trial, there are many other what we call smaller trials. We call them sub-studies that are unique to that person's mutation that has caused that cancer. So again, lung cancer being an example, if they had an ALK mutated lung cancer, they would go on one study. If they came into a lung cancer basket trial, or if they had a KRAS mutation, they would go on another study. Similarly, in the Beat AML trial, and this is unique because it is completely funded and sponsored by the Leukemia Lymphoma Society, which is a nonprofit organization. It's not sponsored by a drug company because we know that has different objectives when a trial is paid for by one entity versus the other. And the objective of the Leukemia Lymphoma Society was like, hey, our older patients with AML, which is the most common population, really don't have great treatment options. Our typical treatments don't work as well and are more toxic. We need to do better for them. And so this is a great, I think, attempt and a fabulous, I think, mechanism by which if you are an older patient, and the old is defined here as 60 or older, that age obviously changes with the age of your oncologist. I'm just kidding. But you know what I'm saying. And so this trial, again, to reiterate, 60 or older with newly diagnosed AML. The unique thing about this trial, like I said, it does not have a pharmaceutical sponsor. It's sponsored by a nonprofit that's dedicated to helping people with blood cancers. And the LLS has formed these great collaborations with different companies that do have targeted therapies that they want to explore in an older patient population. And so once the patient enrolls on the trial, within 7 days, we get back all of the information about their leukemia, all their diagnostics, all their mutational status. And so then we have the power and the knowledge to offer them the right sub-study based on their genetics. And if it's a targeted therapy, that's great. If it's something that's different, bispecific, or anything that we have available, then that's what they would get offered. One other thing that we're doing, which I think is so critical for our patients, but I think very few times is this ever done, is we are revisiting trials that have already been done that have determined a dose that is supposed to be effective for our patients. But then we realized once we started using it in real life, right, that it probably wasn't the right dose for our patients, that it probably was too much drug and that we are causing more toxicity, especially in our older patients. And so the Leukemia Lymphoma Society is very committed, as we all know on this call, to making our patients' lives better with blood cancers. And so it is truly funding with people like you who are supporting the society and donating a trial that optimizes the dose of a certain drug for older patients with AML. It's called the OPTI-AML trial, and it's part of the Beat AML trial as well. And I just think that's such an amazing thing to do because it just is something that, isn't the next best targeted therapy, but it is so critical for the lives of so many older AML patients that are being diagnosed and treated every day.
Wonderful review, and it is a wonderful trial. If you would tell us about one or two clinical trials you're particularly excited about, and also I just love your view on clinical trials in general.
Yeah, so I am biased, right? I do clinical trials for AML. I do clinical trials for all myeloid malignancies. I work at a clinical trial center. But I do think we have it a little bit backwards in the way we do clinical trials here, because really the most people with any cancer are going to be treated by people like you. They're going to be treated at any place that's close to them, that's in their community. And patients don't want to leave their communities because that's where they have the support, right? Already
True.
having a cancer diagnosis puts a huge stress on your family. And now you're going to tell your caregiver or your loved one, drive me 2 hours to the big hospital that's telling me they have the next best clinical trial. And that's just not feasible for a lot of patients, even though they may want to do that. So my take on clinical trials in general is we should absolutely be offering them and prioritizing them for all patients. But I think that's easier said than done because we don't have the resources and the setup in this country, at least, where a majority of our population does not live close to a large academic cancer center to actually do that. And that's where I feel like organizations like the Leukemia Lymphoma Society can really help bridge that gap. In terms of the trials I'm excited about, I think as we talked about in this program, the menin inhibitors are sort of the exciting thing in AML. Most of the trials in menin inhibitors have been done in what we call relapsed refractory AML, but now we have multiple trials for newly diagnosed AML patients, which is really where we want to use our most effective therapy so that they don't hopefully ever relapse. And so those are something that we're very excited about. There's multiple menin inhibitors. Hopefully all of us can offer a trial like that to a patient with an NPM1 or a KMT2A rearranged AML.
Terrific. So again, this is Dr. Ken Miller. I want to say this has been such a great discussion about AML. And I have to say how different it is from sort of the landscape of AML when I was a resident, when I was a fellow, when I was a husband, and going through this with my wife. So how exciting all these changes are and really encouraging. And we've been joined today by Dr. Uma Barate, who is an associate professor in the Division of Hematology and the Acute Leukemia Clinical Research Disease Group leader at the Ohio State University. Uma, thanks so much for being with us.
This has been a great conversation, Ken. I thank you and the Leukemia Lymphoma Society for giving me this opportunity. This has been awesome. Thank you.
Thank you. I want to thank all of you for listening to this terrific episode and for a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources. Please visit lls.org/CE. For any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. LLS also provides other resources for patients, survivors, and their families that can be found at lls.org/support. I want to encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. And we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society, and access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.